Hi, my name is Emily Heil. I'm a professor at the University of Maryland School of Pharmacy, joined here by my colleague, Julie Justo.
Hi, everyone. I'm Julie Justo. I'm a clinical pharmacist lead in infectious diseases at Dartmouth Hitchcock Medical Center in Lebanon, New Hampshire.
And we are looking forward to speaking with you today about aminoglycoside dosing for the treatment of serious gram-negative infections. Here are our disclosures for your reference. And by the end of today's talk, we hope that we can outline some of the background PK/PD targets for both safety and efficacy with the aminoglycosides. And importantly, we're specifically focusing on the treatment of serious gram-negative infections today. So we're not really thinking about gram-positive synergy, mycobacterial infections, but when you're really using the aminoglycosides for these serious drug-resistant gram-negative bacterial infections. And then we'll talk about some strategies for executing this in real practice. So why are we still talking about aminoglycoside dosing to begin with? These are older agents. We have novel beta-lactam, beta-lactamase inhibitors, and wonderful new drugs available to help us target drug resistance. But unfortunately, we are still facing an era of increasing antimicrobial resistance where we're seeing some bad bugs that we still don't necessarily have optimal treatment options for. And some of those novel agents aren't necessarily available to us in all countries. So figuring out how we can optimize our aminoglycoside dosing to still keep them as part of our antibiotic repertoire is essential. So where we've been with our aminoglycoside dosing in history, back in the 1990s, we learned that we can really adjust how we dose our aminoglycosides to maximize efficacy while minimizing toxicity. So thinking about this hammer and nail analogy, taking out your bigger hammer and coming out with a larger dose to really drive that bacterial burden down earlier in the course of therapy with this extended interval dosing concept, using higher doses less frequently versus the more conventional dosing that we're using prior with our smaller doses or smaller hammers, providing the dosing more frequently. So that really took off in the 90s and then followed in the early 2000s by the use of nomograms, where these higher therapeutic doses were given and then monitoring was done with just a single aminoglycoside concentration, typically drawn within 6 to 14 hours after the dose was given or after the end of the infusion, plotted on a nomogram to then define the interval to make aminoglycoside dosing relatively simple and straightforward. We were still occasionally doing two-level PK, breaking out our big calculators and doing our traditional first-order kinetics, but this was typically reserved for patients that were excluded from the nomograms. So this populations that were not well studied or not well described, or due to changes in their volume of distribution, for example, were excluded from nomogram dosing. So this includes patient populations such as cystic fibrosis, patients with significant burns, pregnant patients, so on and so forth. So to dig a little bit into where this our PK/PD targets for clinical or preclinical data for efficacy came from, I want to point you first to this paper by Bill Craig, who's kind of one of the legends in aminoglycoside dosing and PK/PD targets. And so here's where you can look across and see your change in bacterial burden in an animal model over time based on a couple of our different classic PK/PD parameters. So the first one being the 24-hour AUC to MIC ratio, followed by peak to MIC ratio, and then finally time above MIC. This was looking at amikacin for Enterobacterales in a mouse sty model. And as you can see, the best correlation was really with this 24-hour AUC to MIC ratio, followed not too far behind by peak to MIC. There was also similar comparison data with amikacin for Pseudomonas that also found the same relationship where AUC to MIC was the strongest of the relationships, but peak to MIC followed close behind. And maybe not unlike the story with vancomycin, where we've known for a while that AUC to MIC really is the best descriptor of PK/PD in vitro for this agent, but we often utilized more of a peak to MIC practice in real life due to the ease of monitoring. But as you can see very clearly here, AUC to MIC is the strongest descriptor of the relationship with this agent and these organisms. Also to show that this is also consistent across all three of our most commonly used aminoglycosides and some of our more common bacteria. So in these first two graphs, we've got our Enterobacterales described for amikacin, gentamicin, and tobramycin, looking at the correlation between our plasma AUC to MIC ratio and the change in bacterial burden over time from both a murine thigh model and a murine lung model. And then on the far right, we've got Pseudomonas aeruginosa for all three drugs. Again, you can see this really tight description and relationship between AUC to MIC for the three common aminoglycosides and our most commonly evaluated and utilized organisms that we use to treat these for. So translating this into a number that you would chase in practice, on this table here, you can see if you look to the middle for a 1 log reduction from baseline, which is one of our typical goals when we're looking at PK/PD targets for Enterobacterales and for Pseudomonas. You can see this number of around 84-ish here for both organisms is really the best proposed PK/PD target for a 1 log kill. Practically speaking, you could think about this as greater than or equal to 80, but this is going to help define a number for us to target in practice. And I'm now going to hand it over to Dr. Justo to go over a little bit more of the clinical data for that.
Thanks, Dr. Heil. So she did a really good job going through the status of what we understand when it comes to PK/PD targets for aminoglycoside efficacy of gram-negatives in the preclinical space. Switching our hats a little bit, what data do we have in human beings? So there's 3 illustrative studies that I wanted to summarize for you guys today. The first one being a very well-known classic study by Moore and colleagues from 1987. So this trial looked at over 200 patients that were being treated for primarily urinary tract infections, bloodstream infections, and pneumonia with gentamicin or tobramycin or amikacin. And again, the majority of the study was actually gent and tobra. And what this study showed is, as depicted in the figure on the right, a higher Cmax to MIC ratio measured in the patients was associated with a better probability of clinical response. And you can see here that a Cmax to MIC ratio in responders averaged around 8.5 compared to only 5.5 in non-responders. And that difference was statistically significant. Important to note, AUC to MIC among these patients were not specifically calculated, but the groups noted between responders and non-responders had basically comparable trough to MIC or Semin to MIC ratios, suggesting that the shape of their curves, if we were to have calculated AUC to MIC, would have demonstrated higher AUC to MIC ratios in the responders compared to non-responders. So this study showed, importantly, that there was an over 90% response rate associated with a Cmax to MIC ratio, specifically of at least 10 or more. And again, that's depicted in that graph. So a lot of folks have discussed this when talking about, big hammer, give a big dose of an aminoglycoside, achieve that peak to MIC ratio of at least 10, kill the bug dead and let it ride. And so we have a few other clinical data that we felt were also helpful in describing a clinical PK/PD target. The first one was from Kashuba and colleagues in 1999, and that it was a slightly smaller study in 78 patients with nosocomial pneumonia. Notably, this study excluded amikacin, so it's just gentamicin and tobramycin. And importantly, they utilized traditional dosing. From what we can glean from the report, it was approximately 2 milligram per kilo given IV every 8 or every 12 hours. Those are the most common frequencies noted. What they found was, again, a peak to MIC ratio of at least 10. And in this time, they did measure AUCs. So 24-hour total AUC to MIC ratio of at least 150 or at least 175. Those PK/PD measures were associated with a 90% or more likelihood of either temperature or leukocyte resolution by leukocytosis resolution by day 7, respectively. So peak to MIC ratio was important, and the 24-hour AUC to MIC ratio with slightly higher exposures than we've noted before were associated with clinical signs of resolution amongst the patients, be they either temperature or leukocytosis resolution, respectively. So that's important data as one of the earliest signs that AUC to MIC ratio can in fact still be associated with clinical effectiveness. The third study to look at is by Smith and colleagues in 2001. This is a very small study of 23 patients. It pooled clinical trials. In this particular study with tobramycin, it ended up being the clinical trials of intra-abdominal infections and pneumonia that were pooled for this analysis. And tobramycin was dosed to achieve a peak of 4 to 10 and simultaneously a trough of less than 2 milligram per liter. This study noted that tobramycin clinical success was increased if the patients achieved, again, a 24-hour AUC to MIC of at least 110. And the patients that did achieve that threshold, which was determined by CART analysis, had a chance of clinical success at 80% versus those who did not, which had a clinical success of only 47%, and that was statistically significant, which is interesting considering how small this patient population in the study actually ended up being. So a dramatic difference in clinical outcomes based on this CART-derived endpoint. Based on these 3 clinical studies, right now, Emily and I, as experts, would recommend to you the proposed PK/PD target for clinical success seems to be a peak to MIC ratio of at least 10 or more, combined with a total AUC to MIC over 24 hours of at least 110 or more. And I think there's still a little bit of research that needs to be done to clarify this further, but we feel like there's sufficient clinical data to point to this proposed PK/PD target for clinical success. So at this point, if you're following along, you're like, well, why don't we just stick with what we've always done and target an aminoglycoside peak to MIC ratio of 10 or more? And there's a couple of reasons that Emily and I probably would go against that. And the first one is that a peak to MIC ratio is a transient pharmacokinetic measure that's solely dependent on the volume of distribution for the patient, which means ultimately across the whole human population, it's less reliable and more volatile of an index. You can, in fact, have somebody that has a low peak to MIC ratio and still achieves a target AUC to MIC over 24 hours that you could be looking for, as one example. Next, preclinical data show that the AUC to MIC over 24 hours consistently demonstrates a stronger association with bacterial kill versus peak to MIC ratio. So that goes to the original animal model data that Emily showed you a few moments ago. Third, the clinical data demonstrate that an association is seen between peak to MIC and efficacy. All of that association was with traditional dosing. So for traditional dosing, achieving a peak to MIC ratio of at least 10 or more confers a very high probability of also achieving that target 24-hour AUC to MIC ratio of at least 84 or more. So we really, agree that we probably need more clinical data to demonstrate the effectiveness of the targets that we're proposing here in this particular presentation. But clinically, Emily and I have been doing this for a while now, and we personally frequently target a peak to MIC ratio of at least 10, combined with a total 24-hour AUC to MIC of at least 84. And again, for practical reasons, we'll kind of put that lower end of the AUC to MIC ratio at 80, just for logistics and measurements in our patients. So this is kind of what we're using to optimize effectiveness of aminoglycoside therapy for the treatment of serious gram-negative infections. Now we're going to switch gears a little bit and start to talk about what do we understand for PK/PD targets when it comes to safety with aminoglycoside use for these serious gram-negative infections. This first slide is talking about nephrotoxicity. The risk factors that we know are associated with nephrotoxicity with aminoglycoside use are, as one would surmise, increased aminoglycoside exposure. So each of these factors has been demonstrated in prior literature. They include increased total 24-hour AUC, as well as the cumulative AUC measured over the entire duration of therapy. Increased troughs have also been associated with increased nephrotoxicity, and finally, increased days of therapy. Particularly, the data demonstrate that something kind of happens around 7 days, especially going into 14 days and more. The risks of nephrotoxicity really kind of take off around that time period. Of course, predisposing patient factors also increase the risk of nephrotoxicity. These would make sense as a clinician. Concomitant nephrotoxins, increased age, especially our geriatric population, and those with pre-existing kidney disease would all be at increased risk of nephrotoxicity at baseline. An important thing to understand about the toxicodynamics that are published for aminoglycosides and nephrotoxicity It does seem that extended interval dosing is associated with a decreased risk of acute kidney injury if the therapy is kept at less than 7 days of total duration. However, this beneficial effect of extended interval dosing strategy uh, diminishes right around 7 days. And this is likely due to the aminoglycoside accumulation that happens inside the renal cells. So, with every successive dose of an aminoglycoside, while at first you get less accumulation in the renal cells to begin with, by probably about a week of therapy, you're getting enough aminoglycoside in the person, even with extended interval dosing strategy, that the nephrotoxicities of extended interval kind of approach the probabilities of toxicity with traditional dosing. So that's something to kind of keep in mind. We're still learning about nephrotoxicity risks with aminoglycosides, but I think a unique thing about this class of antibiotics compared to others is that time or days of therapy is particularly important. The last thing that is shown here on the right-hand side are toxicodynamic curves of nephrotoxicity that come from the Ryback and colleagues paper in AAC from 1999. And this just kind of demonstrates when aminoglycosides are given twice daily versus once daily, that you have a shift to the right with once daily. That kind of demonstrates the benefit of the extended interval dosing. But again, most of these patients were on relatively shorter durations of aminoglycoside therapy, and it's possible that these toxicodynamic curves would change with longer durations of therapy. Another important adverse event with aminoglycosides that we always want to monitor for is ototoxicity. There's unfortunately even less understood about the toxicodynamics with aminoglycosides and ototoxicity. A few things, though, have been borne out in the literature. Risk factors, again, still seem to include increased aminoglycoside exposure. So these increase the risk of either vestibular or auditory toxicity when it comes to aminoglycoside use. Increased aminoglycoside exposure has been characterized most frequently as the cumulative AUC. There was one interesting paper that also described it as the increased baseline area, which is the mean trough of the aminoglycoside multiplied by the duration of therapy in days. So basically, the overall tonnage of aminoglycosides that this person's body sees is related to the risk of ototoxicity. In addition, just similar to that risk factor, increasing days of therapy, again, particularly longer durations, over 10 or 14 days, are associated with ototoxicity, which for most patients, if it does occur, seems to occur at a longer time point than potentially even nephrotoxicity would. Another important risk factor with ototoxicity is prior treatment with an aminoglycoside, which again is potentially related to the overall cumulative exposure to aminoglycosides to the cells of the inner ear. Predisposing patient factors also exist, and there's a unique one with ototoxicity that is worth remembering, which is if a patient has a pharmacogenomic variant of the mitochondrial gene MTRNR1, the variants specifically are the ones listed there on the slide. The possession of that variant significantly increases the risk of ototoxicity in that patient, regardless of duration. There are reports of patients experiencing ototoxicity as quickly as after one dose of an aminoglycoside. So this is particularly important in our pediatric population. So for example, our CF population, there are some centers that are even testing for this ahead of time, which is pretty progressive work and emphasizes the importance of precision dosing in these patients. And then of course, a predisposing factor also exists with chronic kidney disease, just because that would increase the overall exposure, that would increase the chances of accumulation in the inner ear cells. The last thing on this slide that's worth mentioning is there are data on ototoxicity, particularly with amikacin, which tends to be used for mycobacterial infections for longer durations of therapy. These are the best toxicodynamic curves that we're aware of that are published in the literature relating aminoglycoside ototoxicity together. And what you can see is that, again, it's that cumulative AUC, which is shown in figure A at the top, but also duration seems to have a similar toxicodynamic curve. And so these can be kind of longer. It's difficult to kind of parse out exact numbers or tonnage of amikacin in this case that would relate to ototoxicity. So a lot of that work is still ongoing. All right, so all of this to say that at this point, Emily and I practice in the following manner. For gentamicin and tobramycin, clinical data suggest a peak of about 10 milligram per liter and a plain 24-hour AUC of about 110 to 120 milligram per liter are relatively safe with low rates of nephrotoxicity of about 1 to 2% and relatively low ototoxicity rates of anywhere from 0.1 to 6.9%. And some of that range is based on like how they actually measure ototoxicity in the studies. Data regarding the safe upper limit for amikacin are unfortunately lacking at this time. We really need additional research into whether we can safely target, for instance, a 24-hour plain AUC of 320 milligram hour per liter to achieve 1 log bactericidal kill of an isolate that has an amikacin MIC of 4 milligram per liter. That example that I'm demonstrating for you would be something where you're still trying to target that minimum 24-hour AUC to MIC ratio of 80. However, understanding that an isolate might have a borderline high MIC of 4, we're not quite sure whether targeting a plain AUC of 320 is safe, and if so, for how long. The last comment that I'll make on this particular kind of linking it all together, putting it all together, is it reasonable to shoot for AUC to MIC in our patients? Well, guess what? AUC dosing actually isn't new. Barclay and colleagues published a study in 1995 in AAC where they did just this, what Emily and I are proposing for precision dosing for aminoglycosides. This study represented 100 gentamicin courses in about as many patients in New Zealand hospitals. They targeted a 24-hour AUC of about 72 to 101 milligram hour per liter, and they utilized the AUC targets to adjust the total daily dose of gentamicin that they were giving patients. So they started right around 5 to 7.5 milligram per kilo once a day, dosed using lean body weight, and kind of went from there. They performed AUC calculation using the Sachs-Zaszky method, getting a peak 1 hour after the start of the infusion and a second concentration that was a random gentamicin level 6 to 14 hours after the start of the infusion. So that's a lot of us are very familiar with Sachs-Zaszky method and performing this type of calculation, but it was nice that they did it directly from their patients. Here you can see on the figure on the right, the smattering of random gentamicin levels that they got. That's what's represented by the dots. And then the solid line represents what they felt was their upper limit of gentamicin exposure that they would be comfortable with. So most patients hit the target exposures that this particular trial was designed to achieve. And what they ended up finding was with the strategy of AUC-based dosing, there was a numerically decreased variance in the final AUC among all of their patients compared to the initial AUC. So TDM based on AUC was in fact at least numerically helpful in decreasing the variance and getting patients toward the target exposure that they were shooting for, although this wasn't a statistically significant difference in this trial, which I think is important to note. In order to get to those target AUCs, the range of doses that they actually had to give patients was even wider than where they started. So they ranged anywhere from gent doses of 1.8 all the way up to 14.6 milligram per kilo. Again, kind of supporting the case for precision dosing of aminoglycosides for these indications. Nephrotoxicity and ototoxicity rates are similar to the ranges that I've provided to you before. And from an outcomes perspective, there were no deaths related to antibiotic failure in this trial, though the authors acknowledged that further research into clinical effectiveness was probably necessary. So all this comes down to, well, if you're starting aminoglycosides in 2024, how should we be dosing them? Putting all of these data together. This is our current approach for initial aminoglycoside dosage regimens by baseline renal function. So looking here, you'll see doses given for gentamicin, tobramycin, and amikacin for a variety of baseline renal function strata, going from augmented renal clearance, anywhere from 100 and just above 120 to just below 240 mils per minute, all the way down to patients with renal dysfunction between 30 to 45 mils per minute. All of this initial dosing with slight variations in the dosage interval would be expected to achieve the AUCs that are shown in the figure on the right. So these data come from Sujata Bhavnani from ICPD and USCAST. She has a wonderful presentation that's cited here at the bottom of the slide. I would encourage you to take a look at these if you're trying to understand how is this table actually going to, how is it simulated to result in key exposures in our patients. What's really important is that this table with these initial dosage regimens would probably result in the vast majority of the human population achieving an AUC between 80 to 120. That's those interquartile ranges in the box plots that are shown here across all of these different renal strata. So this is what we feel is a reasonable starting point for the vast majority of patients right now, assuming that we're shooting for those PK/PD efficacy and safety targets that we discussed before. And underpinning this is a lot of science that Dr. Bhavnani has done looking at probability of target attainment. This is one example utilizing the comparison of tobramycin and Pseudomonas aeruginosa. And here you can see across all the Monte Carlo simulations that she performed utilizing that initial dosage regimen that we talked about on the prior slide, it will be estimated that, for example, 96.6% of the simulated patients would achieve the 1 log kill target of total AUC to MIC over 24 hours of at least 84 if the Pseudomonas aeruginosa MIC was sitting at an MIC of 0.5. So if you're looking here on the graph, you can see 1 log kill is with extended interval dosing, which is the red line, is going to be right here. So at an MIC of 0.5, plenty of folks are hitting that target. However, the probability of target attainment definitely drops off as soon as you get to a doubling dilution MIC of 1, and it's very low likelihood of achieving that if the MIC is 2. So that's with the initial dosage regimen that was given on the previous slides. If we were to target 1 log kill with MICs of 1 or 2 in Pseudomonas aeruginosa, Emily and I would make the case that precision dosing is really necessary in those patients. There are lots of other data that talk about each one of the other aminoglycosides across Pseudomonas aeruginosa and Enterobacterales. For the sake of time, we're not going to go through each of them today, but if you're interested, we highly encourage you to review this citation for more information. And with that, I'll turn it back over to Dr. Heil.
Thank you. So putting this all together, how are we going to actually implement this in practice? So there's really 2 key things that are needed to optimally dose aminoglycosides in real life, and that is having access to timely therapeutic drug monitoring, meaning you can get an amikacin, a gentamicin, or a tobramycin level within 24 hours at your institution, and also having data from your microbiology lab, specifically an MIC for the organism. These 2 data points are essential to be able to do this precision dosing that we've been speaking of. And then in terms of methodology, there's a couple of ways to go about it. So of course, sort of the emerging gold standard and the ideal that we're all shooting for is to be able to use model-informed precision dosing, or maybe you've heard of it more familiarly as like Bayesian modeling. So using a software program that's going to have a prior and posterior model in it that's going to use data from some of the studies that Dr. Justo just described to take your individual patient's data in the context of larger PK/PD models to provide the optimal dosing recommendations for your patient. That being said, if you don't have access to one of these modeling programs, that is okay. We still have our good old Sawchuk-Zasky method, our first order PK equations that we can use without any need for any kind of fancy software subscription or anything along that lines. There are commercially available and homegrown platforms for Bayesian modeling. And then for Sawchuk-Zasky, you can just use your big old TI-83 calculator, or you can find online Excel calculators, other ways to kind of simplify the math for you. But what is important with both of these strategies is that you are going to need two quantifiable aminoglycoside serum concentrations for either. So again, going back to what Dr. Justo talked about a couple of slides ago, you want that 2-hour post-distributional peak level, and then a level drawn about 6 to 14 hours later. But importantly, you want to make sure it's going to be quantifiable, meaning you're not necessarily getting like a trough concentration where it could be undetectable by your lab's lower limit of detection, and you won't know for how long it has been undetectable. So we need actual quantifiable levels to be able to do these calculations accurately. Now, one of the advantages of the Bayesian methodology is that it can be feasible with just one concentration versus two, but in all likelihood, we really need more clinical data available on the accuracy of these programs before we would feel comfortable endorsing using Bayesian with just one level. So regardless of the strategy you're using at this point, we would strongly encourage two quantifiable aminoglycoside serum concentrations. Now, the alternative would be the nomogram strategy that we've all become very comfortable with because of the ease of monitoring, the use of that single random concentration. So something like the Hartford nomogram, which you can use where you give your patient that set dose in the beginning, you get your random concentration 6 to 14 hours later, plot it on the nomogram to get your interval, and go from there. But it's really important to remember that the reason we're saying this is an alternative is because these nomograms were designed to target that Cmax to MIC ratio of 10, assuming an MIC of around 2, but they weren't designed to target these AUC to MIC ratios that we've now hopefully sold you on as being the ideal target for efficacy with these drugs. So this is a possible strategy if you don't have the precision dosing resources or the rapid access to TDM, but we would say that this is definitely more of an alternative at this point. Another thing to bear in mind is that we have a broad differential of interpretive breakpoints across organizations depending on what your microbiology laboratory uses for their breakpoint setting organization. So this table is largely meant to serve as a reference, but just to highlight one particular example from what we've been talking about today, if you zoom down to the row of tobramycin for Pseudomonas aeruginosa, you can see that the recommended breakpoints across these 4 different organizations are extremely different. So CLSI recommends less than or equal to 1, the FDA less than or equal to 4, UCAS less than or equal to 2, and then USCAS, these are proposed recommendations from that presentation from Dr. Bhavani that we've mentioned before, actually recommend less than or equal to 0.5. So taking UCAS as an example, if your lab uses that as the breakpoints, you'll recall from just a couple of slides ago, the probability of target attainment for Pseudomonas with tobramycin that has an MIC of 2 was exceedingly low and would be potentially very challenging to target safely with this agent. So it's really important to have an accurate MIC from your lab and also understand what breakpoints they're using. Which leads us into some ongoing challenges. We haven't answered every question with how to optimally dose these agents yet. So a couple things to make sure you're keeping in mind. These exposure targets that we've discussed today are really well validated for our Enterobacterales and for Pseudomonas, but for other gram-negative organisms like Acinetobacter baumannii, Acinetobacter is a good example, I guess, but for other gram-negative organisms are really unclear. We don't have that clinical data to support these exposure targets. We also, if you're in a country that has access to plazomicin, one of our newer aminoglycosides, we really lack data for this agent specifically outside of complicated urinary tract infections. It's likely that because the PK of plazo is similar to amikacin, we could utilize some of the same dosing targets and dosing strategies, but we really don't have that precision dosing available and the data for that agent in serious gram-negative infections. And most institutions probably don't have readily available susceptibility testing or therapeutic drug monitoring available for this agent. And then finally, and maybe most importantly, is what MIC should we be using in our calculations? For empiric dosing, in all likelihood, we could use epidemiologic data and assume for like gentamicin and tobramycin, perhaps an MIC of 1, at least in the US, based on our MIC distributions. This is likely a reasonable empiric number to use in our calculations. For amikacin, it's a little bit less clear, perhaps aiming for an MIC of 2, understanding that there's risks and benefits of whether or not that's going to be adequate coverage are important. Also, depending on what platform your microbiology lab is using for its automated susceptibility testing, you may not even be able to get a specific MIC down to the level that you want. So for example, E. coli susceptibility to gentamicin in your lab may only be reported out as an MIC of less than or equal to 2 because your AST panel does not offer a dilution any further than 2. So does that mean your organism's MIC is 0.5? Is it 1? Is it actually true? Is it 2? That can make your empiric dosing and your calculations more of a challenge. If your lab is using Kirby-Bauer testing, of course, that's more of a qualitative method and is not going to provide the MIC for us. And then in all labs, whenever we're dealing with MICs, there is going to be a degree of imprecision in our clinical laboratories. So there is that kind of plus or minus 1 doubling dilution on either side of the number given to us that's possible. And so this is something we have to keep in mind. We put a lot of stock into this MIC, but it's not necessarily a perfect value. We've also spent most of our time today focusing on patients with relatively normal renal function, other stable PK/PD parameters. We lack data for optimal dosing of aminoglycosides in some of these special populations where you are going to see a difference in volume of distribution over time, like our pregnant patients, our patients with cirrhosis, our burn patients, patients with rapidly fluctuating renal function, and particularly patients on hemodialysis, peritoneal dialysis, other forms of renal replacement therapy, still an area where we need more data. And we've also, as we mentioned earlier, really only covered targeting gram-negative infections here. There is some ongoing work that needs to be done in optimizing our dosing for things like gram-positive synergy for endocarditis and the use of these agents for mycobacterial infections. Dr. Justo, do you want to wrap us up?
Sure. So in summary, aminoglycoside PK/PD targets for efficacy and safety based on the literature that we've seen to date would be a peak to MIC ratio of at least 10, along with a 24-hour total AUC to MIC of anywhere between 80 to 100, possibly 80 to 120, looking at some of that literature. I think that upper limit still needs a bit more research to finesse. And we would say there's caution with amikacin at MICs of 4 milligram per liter. It would be very difficult to achieve these targets at those MICs. So we would consider the benefit to risk ratio of using an aminoglycoside in that setting. Precision dosing strategies are available and have been applied to aminoglycoside dosing for decades. We like them. We think we should be doing them more. So these include options like MIPD or Bayesian, which are some of the newer solutions on the market. And then good old Stachek-Zasky also works as well. With the ongoing threat of antimicrobial resistance, we should be prepared to apply modern precision dosing methods to this older class of antibiotics. And with that, Dr. Heil and I can be reached at the contact information here for anyone that has questions or comments on this presentation. Thank you for your time.